Good morning. Thank you for coming to today's Medicine Mind the Gap lecture series featuring Dr. Scott Richardson. Mind the Gap is a lecture series that explores issues at the intersection of research, evidence, and clinical practice, areas in which conventional wisdom may be contradicted by recent evidence. From the role of advocacy organizations in medical research and policy, to off-label drug use, to the effectiveness of continuing medical education, the seminar series aims to engage the NIH community in thought-provoking discussions to challenge what we think we know and to think critically about our role in today's research environment. Today, Dr. Richardson will discuss the various facets of evidence-based medicine, what it is, why we need it, and how to practice it. He will engage in a discussion on how clinicians can learn to practice evidence-based medicine even if they have already completed their formal training. He will also examine what it would take to incorporate evidence-based medicine into the newer curricula of medical schools, illustrating how his teaching institution is doing this. Dr. Richardson is an academic general internist at the Georgia Health Sciences University, the University of Georgia Medical Partnership Campus in Athens, Georgia, where he is professor of medicine and campus associate dean for curriculum. His principal scholarly interests are in clinical epidemiology, evidence-based healthcare, and medical education. He is co-author of the book, Evidence-Based Medicine, How to Practice and Teach It. Dr. Richardson continues to work on the challenges of integrating evidence into clinical decisions, particularly in evidence-based clinical diagnosis. He also is working to incorporate evidence into the new curriculum at his institution and in medical education at all levels. Please join me in welcoming Dr. Scott Richardson.
Thank you and good morning. Let's see if this works. Sure. You'll see about me a couple things. First of all, I can't read minds. I've worked very hard over the years to learn to do that, but it hasn't worked. I've even gone so far as to turn my hair gray and to lose a lot of it, but still nothing gets in. So if you have questions, I would be delighted to hear from them, but you're going to have to flag me down and say I have a question. I have less than 2 hours of material, so I'm hoping we'll fill whatever time with useful dialogue and questions from the audience. The other thing is that I tend to move around a bit, so you'll have to get my attention by actually moving your hand or something so I can see it. So I hope this won't disturb you. You'll see I use visual metaphor from popular culture as I understand it, although my late teenager daughter has assured me I don't know anything about popular culture. It's okay. What we'll tackle are these three topics in this order, but as you'll see, we can move back and forth. So if your question comes out of sync, it's all right. Just go ahead and ask it. I first want to examine what we mean by evidence-based medicine or practice or healthcare and think about why we need it and what it is really that we're not doing maybe in some certain circumstances and what we could be doing if we were to be using it. And so to do this, what I'd like to start off with is if everyone could raise their right hand. All right? Now keep it up in the air if you would like your health system to routinely provide the polyvalent pneumococcal vaccine, not the new one, but this one, to high-risk and elderly persons to prevent pneumonia and death. Keep it up. All right, so that's most of you in the room. I can't see the webcast folks, but I'm guessing a lot of them would have their hands up as well. And I'll pick up the thread of that story in just a little bit as we examine this. I now face the problem also of dealing with novice clinicians, and we want to help our first and second year students before they head off to the wards to understand the science that guides clinical decision making. And so this raises the additional question what we would want to do as a health system, but also what we should do educationally to help people understand how these decisions get made. And so let's start with what we mean. I think of evidence-based healthcare as the broadest of the terms, Evidence-based practice is the term that has to do with the care of individual persons, whereas healthcare might be the care of all peoples in populations or population subgroups. And of course, there's evidence-based education, evidence-based librarianship, evidence-based this and that. I was recently sent a reprint that there's now evidence-based business management. So the ideas of making well-informed decisions are starting to appeal to people beyond healthcare, and they're holding up healthcare as the example. Interesting. And so what do I mean evidence-based? It really has to do with this idea that we conscientiously, explicitly, and thoughtfully use current best evidence from clinical care research in our work, whether our work is actual clinical practice or in broader issues of healthcare or education or elsewhere. And it's a recognition of the following. 150 to 200 years ago, the knowledge that was used for clinical decisions was primarily of one sort: clinical expertise, those hard-won lessons from doing it over and over. And now in this century, we think it's more complicated. There's still clinical expertise. And I want to be clear, I'm not arguing against the use of clinical expertise. You don't want an inexpert healthcare provider. You want somebody who's good at their job. What we're, in a sense, arguing for is the addition of consideration of all these other things. The knowledge from the studies of human biology. That's why you exist, right? The NIH. There's also knowledge of studies of health systems and how translational research can influence. But in addition, there's the recognition in the last century and now this century of patients' perspectives and how they can and should influence decision-making and so forth. Their particular circumstances, the health systems, our ethics. So what we're talking about is adding this one to the mix, not substituting. Okay? And that's the first point of confusion. A lot of people say, how come you're against clinical judgment? I'll preemptively say I'm not. So if you would like to talk more about that, what I think we're talking about is adding considerations of results from clinical care research to the other knowledge that we use and make judgments about. And if you ask people, like these researchers did, they did a survey of Americans and a few thousand were assembled, and they said, do you believe that healthcare services you receive should be based on the best, most recent research available? And it probably won't surprise you that most said yes. Some said no, and I'm not sure what these people were worried about, but that's what we have. It seems like a no-brainer. In fact, a lot of people, when I start in on this conversation, say, really? It's not already that way? So why is it that we need it? Let's go a little bit more deeply. And here are some of the issues. There's an enormous amount of clinical care research that's been published. And although people will complain about this, I see this mostly as success. Success, if no other institution, it's success of the NIH and the enormous public and private investment in research. We have a lot of new knowledge. Now we have lots and lots of it, though. So much so that not all of it is necessarily able to be understood by an individual. In fact, it cannot be done. Over 28,000 biomedical periodicals every year. Nobody can actually even read them to say anything of understand and figure out how to use them. So we have a lot of research, and importantly also its nature has changed dramatically. Whether you think about individual randomized trials or systematic reviews in clinical care evidence, or gene-wide association studies, S&P research. There's an enormous variety of types of research that wasn't there 60 years ago. So the traditions of learning and keeping up to date that we had 60 years ago can be expected to no longer apply. 60 to 100 years ago, we had what you might think of as the passive diffusion model, which is to say new knowledge, as it was slowly made, was published in biomedical journals and talked about by the few who were expert in it, and then that passively diffused through the knowledge workers who needed to know that. And what we've learned over the years, as I'll show you, is that model doesn't work so well now, particularly when there's so many voices and so many other things to consider. Here's another problem. Only a tiny fraction of this is sufficiently valid, important enough, and directly applicable to care. We'll talk about applicability a bit more, but you've heard of this. If you've invested as much as you have in translational research, you know that not every knowledge bit that we yield from biology research is always directly applicable. And you can think of a lot of what's in the research as communication from one group of scientists to others about furthering science, not so much from scientists to clinicians about major advances in patient care. So you've got this problem, an enormous amount. It's different than it used to be. Only a fraction of it is ready to hit the street. We also need it often. Now, if you ask doctors how often they need it, they'll say that they need new information 2 or 3 times a week, and that they usually get it from looking at textbooks or from journal articles. But if you follow them around and say, do you need some now? Do you need some now? Do you need some now? It turns out that there's been a wide number of studies and they've found a wide range, but the average is something like 2 bits of information for every 3 patients seen. And what we tend to do is we're so busy that we either don't pursue the questions or we ask experts. And why is that? Well, the main reason is our usual sources of information don't work so well. The usual passive diffusion model doesn't work. And what do I mean by that? Well, we've already talked about the overwhelming number and scope. Okay? Imagine you need a half a cup of water, and to get it, you have to go to Niagara Falls and somehow get in there, get your half a cup, and get out. Too much for most of us. But in addition, many of the forms of the usual sources have been shown to be ineffective. If you've heard from some of the people I think you've heard from, then you know that the standard didactic lecture, not unlike what I'm doing here, has been shown to not really change much in terms of knowledge and clinical performance unless it motivates you to go off and learn and do something differently. So the main thing a large group presentation can do is to motivate you to go off and learn. And that's useful. But by itself, it often doesn't change practice. And there's been over 100 trials of CME, some showing certain things effective, some ineffective, but the traditional forms don't work very well. Yet that's what we require. So as time accumulates and we have all these questions that either don't get answered or get poorly answered, our ignorance of current best care grows and our clinical competence begins to shrivel. And you may say, well, what's the evidence for that assertion? Oh, and did I leave out, there's too little time. How much time do you reckon doctors have to learn new things? When people have done surveys, they estimate among British general practitioners, they have a half hour per week. And then if you turn to individual practitioners and say, did you get your half hour last week? Only half or so have, which tells you maybe they're not getting it very frequently. And importantly, it's half hour separate from work. So here's the thing, going back to that water analogy. They need the knowledge at the point of care. They're thirsty then. But they don't get it then, they get it later, like several days later. Okay? If this were water, what would we do? We'd build a plumbing system before bottling where we'd go to a tap and out would come purified water. Why isn't knowledge like that? Why isn't knowledge, current best knowledge, delivered to the point of decision making while working in a way that it's right there when we need it, rather than quite a bit later? Yes, sir?
Isn't that what up-to-date is?
So there are products that are now starting to attempt to solve this problem. And up-to-date is one. There's several other point-of-care resources. But you can see why it's only been in the last few years that people have said, ooh, we've got to redo the way we did knowledge, deliver knowledge to the knowledge workers. So there has been research on this business about time and its association with our quality of care. There have been a number of studies, 62 evaluations over time that were systematically reviewed in 2005. There may be other newer evidence as well. From John INODs, we've learned that there are several signals for updates every so often, sometimes as soon as a year after a systematic review is published. So I'd reckon by now that's quite out of date, but I'd be surprised if it shows something different, because there was a strong and consistent negative association between the year since graduation from medical school and our knowledge as measured by tests, our recommendations for diagnosis, screening, and prevention, and our treatment decisions. It turns out that obsolescence is equal opportunity, so that when you examine these data across subgroups, U.S. medical schools, international schools, top of the class, bottom of the class, there's a depressing similarity of the downward slope. And the editorial is to accompany that says, look, it should be no surprise. We need active methods to deliver knowledge, not passive methods. And we can start to customize patients' care from evidence-based standards rather than from old textbooks. Going back to the water analogy in a moment, right here, out of date. Think about this. There's a 3-year or so time cycle from the time a textbook chapter is written to the time it's published, with some exceptions like the electronic texts that are starting to come out. If this were water, we wouldn't tolerate it. If you went over to the spigot and out came 30-year-old water with the accumulated detritus of 30 years of sitting in some tank, what would we do? We'd raise a stink, as they say, and the government would intervene, and we would do something about it. Why isn't that same societal outcry happening about the out-of-date knowledge that we are delivering to our healthcare professionals? And unfortunately, it's often wrong. So what's that about? Let's have a look at these data. You may have seen this earlier, but let's have a look again. These are data from Elliott Antman, published in '92, where they examined a number of treatment trials for treatments for acute myocardial infarction. And this is just one of them, thrombolytics. And yes, I know we have other newer treatments, but work with me on this. On the leftmost is the year. Next in are the number of randomized trials. And third column are the number of patients who've cumulatively been randomized to them. So that, for instance, at this point in the mid-early 1970s, there were 10 trials with just over 2,500 patients. And so that in 1990, there had been 70 trials with over 48,000 patients. In the middle here, this is a cumulative, a systematic review with a cumulative meta-analysis display of the effect size, which is to say mortality reduction from thrombolytic therapy. And here's the line of no difference, where the ratio is 1. And this side favors the treatment, the mortality is lower, and this side favors the control. And I think you see that after 23 patients, there seemed to be a reduction, but there was a wide confidence interval. That blob is the estimate of the effect size, and that line is the confidence interval. And by the time you get to the 10th trial, it is by then statistically significant, showing a reduction in mortality. And that was estimated around 1973. And for the next more than a decade, 60 more trials with nearly 46,000 patients entered into those trials. And our net effect has moved a little, but not our qualitative belief that this treatment saves lives. Now on the other side, though, let's have a good look at the recommendations of textbooks and experts as manifested by what they said. Roughly the same years, they checked sources, either review articles or practice guidelines or textbook chapters, and counted up. It was not mentioned, experimental, etc. And you'll see that even though it was being used here, it was not mentioned in most places. In 1969, it began to appear as mentioned, but as experimental. And it wasn't until this point, so roughly 1987, 1990, that it was recommended as routine care that would reduce mortality. This article demonstrated that experts often lag in their recommendation of life-saving therapy. And the lag can be measured in years, sometimes decades. And during that time, there are millions of people not getting this life-saving therapy. And in the same article, there were treatments that actually caused more harm. And so there were millions of patients receiving those potentially harmful therapies. And not just in this country, all over the world. So you have to start really asking ourselves as a society, why is that? What is it that we're doing or not doing in delivering knowledge to a knowledge-intensive line of work in such a way that we're this far behind what we already know? Why can experts be wrong? Now, I have to say oops. Oh yes, let me pick up the Pneumovax story. Why should we do the pneumococcal vaccine? Early observational studies show its use was associated with lower infections. There's certainly biological plausibility. You vaccinate against the strains, you reduce it. There are definitely surrogate outcomes. You can measure, for instance, that its use is associated with increase in antibody titers. And there are lots of analogies. There are even cherished beliefs. Who wants to be against prevention? No one wants to really come out and say, I'm against it. And of course, there's also these other things that are really more system issues. Low unit cost. Each one doesn't cost that much, so people think it's cheap, even if the aggregate cost is enormous. It has the property of being measurable, so that people could say, oh yes, check, we did it, we're doing preventive services. And experts recommend it, practice guidelines sure do, the manufacturers weren't going to fight us. And these extremist groups, oh, you don't know them by that? Okay, well anyway, these groups recommended the last one gives you demerits if you don't. So you might quite reasonably ask, what's the evidence that shows we should do this? At the time I looked last summer, there had been 3 systematic reviews of 13 trials. I don't know if there are new trials since, but in any case, there might be. 3 of those trials were in healthy persons, otherwise low risk, but in high attack rate situations. Army recruits, South African Highlanders, the New Zealand Highlanders, the South African gold miners. In other words, you take a lot of people who have not been exposed, you put them all live together in close quarters, and the infection sweeps through the camp, and you can show that in that group you can reduce mortality. But in the group of the older and the high-risk patients in whom it's recommended, there have been 10 trials with over 24,000 subjects in all parts of the world, and there's no reduction in the poor clinical outcomes. Total mortality, pneumonia-associated mortality, bacteremia, and so forth. So this gives us pause to wonder how it is. Now, I'm not sure whether we should give this stuff or not, but it does strike me as remarkable that we universally, most developed nations recommend this age group get it. But has it shown a difference? Not sure about that. And this provides us with what the learning scientists call cognitive dissonance, which is we think of ourselves as making informed decisions, and yet we're making a decision that seems uninformed by the information. It should make us somewhat uncomfortable and move us to action. I have compassion for experts. Experts are asked to do the nigh impossible. They are asked to opine early. When we have a new thing that comes out, we turn to our experts and say, well, what do you think? They've often just seen the data just like we have. We also don't like our experts wishy-washy. We want them to be decisive, to be definitive. And so they're asked to have strong opinions formed early. They also have the same problems of cognitive overload, little time, too much information. They may also be involved in the research, and it may or may not be free of their own biases or conflicts of interest. And of course, experts being human, we have all the usual human frailties. In addition, it's a recognized phenomenon about the preliminary evidence it should work with definitive evidence. See, we don't really make a habit of doing trials of things we already believe are stupid. If we don't think it's going to work, that's not what we do trials in. We take our best ideas. Where do those best ideas come from? Animal studies and early observational studies. We take the things we really think should work and try them out. And that makes sense from the point of view of when you're about to embark on a trial, but it means people already have formed opinions about whether it should work. And so those formed opinions are hard to unlearn. And we often confuse these two. It should work with it does work. And many of the experts that I've talked to focus on how something works rather than how well it works. So they'll tell me about how the new monoclonal antibody gloms onto the receptor, interferes with the ligand, and so forth. And I'll say, well, so how are patients on this treatment? Are they better off? Do they have fewer joint exacerbations, this sort of thing? And one of the problems is that up until recently, many experts have not used explicit systematic methods to gather the evidence and make sense of it. So experts are put in a jam, but it does mean we can't always rely on them to know the truth of the matter. But if we did have good quality information, it might make a difference. There had been a systematic review of the treatment of cardiovascular disease from 2007, and they found that patients who got the actual treatment based on trials at the optimal doses for the right duration did better than those who didn't get this treatment, and that the improvement was proportional to the number of treatments they got. Well-informed decisions might make a difference. That's part of the construct here. Why are we doing this? It's because we can't make well-informed decisions without information, and we've learned the hard way that not all information is created equal, and sometimes misinformation is worse. I only got to go back a little bit to the WHI trial, but also to the CAST study. There have been a number of trials, many of them sponsored by this institution, where when we finally put it to the test, we learned the truth is different than the original early studies. And there is evidence that better information can lead to better informed decisions and better outcome. So now we face Morpheus's choice. Do we take the blue pill? Forget this, leave this auditorium this morning, and go back to business as usual? Or do we take the red pill and remember and try and make a difference and try and maybe teach ourselves or teach our colleagues, our junior colleagues in particular, how to make a difference? So feel free to walk out at any point, but I'm going to assume if you stay, you want to hear a little bit more about teaching. So I'd be delighted to answer questions as we go. But let's think about that. How are we going to get this taught? And the first part is to understand what the process is, how it gets done, and some of the principles. So in this slide, I've tried to combine two kinds of things. One in white, the process of evidence-based practice, in which a patient dilemma, or if it's evidence-based healthcare, a population healthcare dilemma. It could be individual patients, subgroups, or whole populations. Leads us to ask answerable questions that arise from that dilemma. Then we acquire evidence that's existing already about the answers to that. Appraise that evidence for its credibility or validity, importance, and applicability. And then apply it. Now we were going with the A's, I think you can see, but apply really here means integrate this new knowledge with our existing knowledge of those several kinds around the human biology, the patient preferences, the health systems, and so forth. And then we act on that and assess the impact of our actions. And this is meant to show, sorry if that's a little dark, meant to show that since patients will vary, those actions may vary. Let's look at these two principles here, and these are the two sort of biggies. This one has a lot of different names, but I think the simplest idea and the least judgmental is that evidence varies in terms of its robustness, its risk for bias, its risk for error, and so some things are more credible than others. And a lot of this goes back to simple ideas of fairness. You know, if you watch two boys throw snowballs and one of them throws a ball and hits a tree, says, see that tree I hit? Yeah, that's what I meant to hit. And the other one says, well, see that tree over there with the kind of crooked notch coming out of it? I'm going to hit that one. Throws it, hits that one. Which one is more credible? Most of our senses of fairness tell us the second one is more credible. And that's the notion of pre-specified hypotheses in research. And many of our ideas about fairness and credibility come at the root from our understanding of fairness. What's a fair test? What would be falsifiable either way? That this could win, that could win, or we could turn out that they're equivalent. This idea of fairness, though, has some formalization from many methods. So epidemiology, both classical and clinical, biostatistics, health economics, lots of different biological sciences. So there are lots of more formal ways that we state credibility, validity, and so forth. But at their root, they have to do with fairness. Then there's importance, which has mostly to do with how well something works or how safe it is, the size of the difference, not its statistical significance primarily, but the clinical impact. Evidence can vary in its risk for bias and error. Some people have said that that means there's a hierarchy, a single hierarchy. I'm not sure there's a single hierarchy for evidence because there's lots of different questions, and therefore the types of evidence you need for those are different, and therefore you might have multiple hierarchies depending on your types of questions. But anyway, the idea is this one, they vary, and we have to be able to sort it out. The second principle is this: when we're applying evidence, evidence alone does not decide. We have to combine with other knowledge and values, and more on that in a bit, but this basic notion is it's informing decisions, not prescribing decisions that we're talking about. So how are we going to get started in teaching? This is Dumbledore using his pensieve to reflect and think. And one of the things I hope that we'll realize is that early on in our reflection, we often figure out, you know, I've got to dust off my own skills. So how are you going to get that done? There's some courses to take. I know Paris and others went to Colorado to take a course there. There are courses in this country and elsewhere. I'm hopelessly biased in favor of taking a course because primarily we're all so busy. Where else do you get the time to concentrate on building a skill in an area that's so unfamiliar to you if you're trying to do it a little bits and pieces here and there? But it can be learned without taking a course. There are, of course, several books, and I'm hopelessly biased in favor of several of them, not just the one I'm known to be a co-author on, but I've contributed to several. So my encouraging you is to go off and learn from any of several. What I'm hopeful of is that you will dust off your own basic skills and start doing it, because that'll help you in a few other areas. Another thing is to make sure you have access to good evidence resources. You've mentioned one up to date, but there are lots of others now starting to come to market, and one of them is none other than PubMed, if you learn to use it well, which you guys are probably at least as familiar with as I am. And this idea that we should learn to optimize the flow of information from those resources is not just having them. A book on its shelf doesn't share its knowledge. It's only when it's in your hand and open that it is working. Same with all the electronic resources. And as we build our own skill and actually do it and practice, another thing to think about is start building some allies. And they may come in all shapes and sizes. Of course you would think of your own colleagues in your own practice, but you might also think, wow, there's a librarian and I need her help or his help, and I've got a clinical pharmacist and I've got all these other players, but there may be other allies, community groups, healthcare journalists, all sorts of people are now saying, this idea speaks to us and we want to work with people who want to do things. I have a lapel pin that I wear on my white coat, and it's in the shape of the yin and yang symbol. And you know, those were meant to show you initially paradoxical ideas that turn out not to be paradoxical. And one side it says, trust me, I'm a doctor. And on the other side it says, ask me about the evidence. Because I actually don't think they're paradoxic. I want patients to trust me and to trust that I will answer them about the evidence, or we'll look it up together and I will help them interpret it. It's not a paradoxic statement. It's not, I don't see it primarily as a challenge, because I want them to feel like we're making well-informed decisions about their care. Now, it's not always easy or fast. We can come back to solving that with products like what you mentioned, but the idea is it's part of our contract to make well-informed decisions with our patients is to use current information. Now, what do I mean by 3 modes down here? I've met a lot of teachers in evidence-based medicine, a lot of wonderful people and gifted teachers, and I've tried to learn from each and every one of them. One of the things I started doing several years ago is started watching how they teach and trying to categorize it into ways that made sense to me. And as I began to do it, I noticed that although I'd met thousands and there were thousands of different individual styles, that there were 3 main methods or 3 main modes in which they taught. And so I thought to myself, oh, what are those? The first one is role modeling. And this is anyone who actually practices or actually does healthcare decisions at the population level, who uses evidence as part of their decision making and are seen by learners to do this. So learners see that evidence and its use, that's conscientious, explicit, and judicious, is part of good patient care or fill in population health or preventive care or whatever it is that you do. This idea being that evidence is not separate from it, it's right there with everything else. In addition, they see who you do it with, what you actually do, when you do it, where you do it, how you do it. In other words, they begin to see through those pragmatics that it is actually possible to do, that it's not an impossible pipe dream. If you teach by doing, they will learn by doing. They can't learn by doing if you don't teach by doing. So this is the first one. And I'd actually wager that if we do lots of this, then we have a certain moral legitimacy when we ask them to learn to do the same. If we don't do this, we come across a little bit like a hypocrite. We're being signaled. Oh, okay. The next one is weaving, or mixing, or some other term. That is, when you're teaching about clinical practice or population health, whatever you do, that you integrate evidence from clinical care research along with other knowledge you use in how you teach, so that learners see using that knowledge from clinical care research, that evidence, as part of good clinical learning. And by showing explicitly how you make decisions and weigh this, you can teach what I think of as vinaigrettes. Now here it is separate, the oil and the vinegar and the spice. Let me give you an example. As a general internist, I'm often asked to teach in the curriculum at my new school the stuff that nobody else wants to teach. And perhaps as a general internist I should know better. But I'm not afraid of these. I'm quite, in fact, fascinated by the problems of the recognition and treatment of fluid problems in our patients. And a lot of it comes down to the combination of the physiology and its the applied physiology of fluid movement across all these spaces in our bodies with the evidence about the different signs for fluid disorders and how accurate they are, and the evidence about the treatments for those fluid disorders. So I take the vinegar, you'll pardon me, I hope, of the physiology, mix it with the oil of the evidence from clinical care research, add some spice with some cases, that sort of thing, and we teach them together. Now remember, if it's wired together, it's going to be fired together. What happens now is that physiology is taught in the first year. When do they learn the evidence about the accuracy of these findings? If they learn it at all, it's in the third year. They can't remember those things that way. If you teach them together, they will learn them together. Now, they may still have memory problems, but at least you can hope that they will wire it together in their memories and access it that way, as the scientists have taught us that we do. The third one is what most people think of that I mean when we say teaching evidence-based practice, and that is targeting specific skills in evidence-based practice. And, you know, whether it's asking questions, it's anything about that cycle. So I'd like to have everyone raise their left hand and then keep it up if you've been to some session where you thought this was happening, where you were learning something about evidence-based practice. Okay, you can lower your down if you haven't. Okay, still that's a lot of you, where you've had something that you were learning that you identified this. And again, what I'd say is, if the other two are happening, if you see people role modeling, if you see people weaving it, then you may be curious, well, how did you know that? I'll tell you a story. I occasionally teach on inpatient attending rounds, and they've occasionally heard before I get there that I'm interested in evidence-based medicine. And so some groups say, ooh, Dr. Richardson, yeah, we've heard you like that stuff, but we don't want to learn that this month. We want to learn clinical medicine. So I say, okay, fine. And I think they're first shocked. And we do it all month long. We don't call it that. We say, oh, we're just trying to make sense of our patients' test results. Which of these is more reliable? This clinical finding, how do you gather it? Well, how accurate is it? This treatment, they seem to be having an adverse effect. Is that a common one, a less common one? All of these things are ways to bring in evidence from clinical care research into everyday decision making without necessarily the label. But about halfway through the month, the brighter teams have figured me out, and they say, oh, wait, I see what you're doing. You're actually teaching us clinical medicine using evidence, and now we want to know how you're doing that. When you said this test result was more reliable than that one, you seemed to pull out a table of numbers, and those numbers spoke to you in a way they don't speak to us. What do they tell you they don't tell me? How can I learn to learn that way? Then you have them. They want it. And usually, they're delighted to learn it if you show its direct relevance. Because why? Most people arrive to me hating statistics already. It's not just neutral, they're in the ground. I'm in a hole. Will Rogers said, if you find yourself in a hole, the first rule is to stop digging, right? So why are we in this hole about statistics? It's often not that much about statistics, and often it's more interpreting the effect size or that sort of thing. And my point of this is, if they see it as foreign to their careers, they typically won't learn it. If they see it as directly relevant to their careers, and you can show them how it fits to the decisions they're going to make, they will happily learn it, particularly if it makes them faster. And I hope to show you some of those ways. You have to start with their learning needs and then build towards what you want to teach them. And this is my reminder. You know, I showed you that kind of round circle. You can think of that as a whole pie. A lot of people think they have to teach the whole thing all the time. I don't really think you do. I think often you can teach smaller slices, and I'll illustrate with just two because they're common, but I don't want you to get bogged down in the details. One is this idea of the probabilistic tradition or evidence-based diagnosis, where there's a scale of probability from 0 to 1 if you're a purist, from 0 to 100% if you're a percentagist. I may have just made that word up. The idea being that it's a way to represent our uncertainty about a diagnosis, whether it's present or not. And that this threshold approach identifies that there is a probability above 0 but not very high, at which we're ready to accept that that diagnosis is not there, even if it really is there, and being willing to take that error rate, because usually the cost of testing or the harm from testing is significant. And similarly, there's a threshold at this end where before we know for sure, we are willing to treat it. What's an example? Well, you may know the story of herpes encephalitis, that back when I was an R1, I realize that's ancient history, although I have assured my daughter there were forks then. When I was in R1, treatment for herpes encephalitis was Ara-C, and the diagnostic test was brain biopsy. And so we didn't really want to give Ara-C if we didn't have to, and we sure didn't want to do that test if we didn't have to. So we had a pretty high threshold for looking for it and a high threshold for treating for it. Now, the diagnostic test, MR, and the treatment, intravenous acyclovir or some of the newer first cousins. So we're much happier testing earlier at a lower threshold, so that test threshold has come down over time, and the treatment threshold has also come down because we're willing to give acyclovir, which is much safer than Ara-C, even if we're not entirely sure they have it yet. So those concepts you probably have a feel for, even if you're not sure where the numbers come from. And again, I don't want to get bogged down in it. But one of the things that's important, and I've worked hard to do, is a lot of people portray this probabilistic approach when they're teaching evidence-based medicine as the way to do diagnostic reasoning. But students have already learned 5 others. They've learned the descriptive traditions, the criteria-based for rheumatic conditions or for psychiatric conditions. They've learned a lot of anatomy, and they understand that a broken bone here is different than a broken bone there. So there's an anatomic tradition, and there's also pathophysiologic and biopsychosocial. So we have to take pains to add the probabilistic, not substitute, because they don't want you to come and take away what they already know. They spend all this hard work learning that, and they're going to defend themselves against you taking it. But I don't think we have to. Adding evidence in its consideration doesn't require us to subtract the other knowledge. In fact, they're probably better as doctors if they can flawlessly, oh, did we go backward? How fun. No, we went forward. In any case, they're probably better if they can flawlessly use all 6. And of course, all this is in the context of realizing that sometimes we are doing analytic thinking and sometimes we're doing pattern recognition. So putting evidence-based diagnosis in the context of actual clinical diagnosis is easier for most people to understand and accept rather than completely wiping the slate clean and starting over for them. So that's a moderately large size slice. Now let's tackle a smaller example, and it's from what I think of as the arc of applicability here. Just this section, how this is going to get done. If we know anything from the last 60 years of biologic research is that humans vary. And they vary in many important ways. And now we're starting to understand why they vary. Genetics, epigenetics, and lots of other explanations for some of it. But some of it may be more than that. A big part, though, is that they vary in their biology, their psychology, their sociology, that define their circumstances as broadly as you can think of it, and the way they value and choose based on their circumstances, and those variations can be represented. Some of those variations have to do with the representation of their baseline risk of bad outcomes from a condition, and scaled without units from low to high. So it could be biologic determinants, social determinants of health, all these determinants of health. There are also some of these same things, but maybe different things, that could determine their responsiveness to a treatment. And still, those same or others could determine their vulnerability to adverse effects. All of these scaled without units from low to high, except this one from high to low. And you'll see why now. Because you can create a cube that represents varying degrees from low to high of risk, responsiveness, and vulnerability, and start asking yourself, if you were the designer of a trial, of a treatment, which group would you want in this trial if you wanted to maximize the chance that you'd find benefit? Well, a lot of you would already go, well, we want people at high baseline risk, so that pretty frequently, pretty soon, we would start seeing people with a bad outcome if the treatment didn't work. We'd also want people who were very responsive and very low chance of having an adverse effect. And so, surprise, surprise, most so-called efficacy trials are up in this corner. And when we then try to broaden the trials to see do they work in other groups of people, those trials are often more like this, where we take high and medium risk, and we take high and medium responsiveness, low and medium vulnerability, and we accept them into our trials. Clinical practice is quite a bit more like that. Okay? Now, we're not really thinking of doing it in the absolutely low baseline risk or impossible responsiveness or enormously high vulnerability, but most of the time we're trying to make judgments about that size from information generated from here. And this issue of applicability can be dealt with often at this conceptual, semi-quantitative, graphical level without necessarily getting into the arithmetic of how this gets done. So if people understand the words and the concepts before they understand the formula and the numbers, that's okay. Many people, this is all they're going to get, but many can go on to the numbers if they've understood this concept. Most of judging applicability of results boils down to saying, are we in this kind of study, this one, or this one? Okay? So that's another small slice that you could learn and then learn to teach as you begin to prepare your learners for their work in evidence-based practice or healthcare. And of course, as you can probably imagine, I'm really recommending that you combine them. You learn each of these three modes: role modeling, weaving, and targeting specific skills, and then teach in the natural context that you find yourself, whether it's classroom or clinical settings, and you adjust these to fit so that you're teaching what your learners need based on your strengths as well. Do you have questions about this before we move on? No? Let's pursue the problem of now, how do you prepare novice clinicians, who are basically senior undergraduates, for learning and practicing this way. And that's the jam I found myself in 2009 when I was asked to be the Associate Dean for Curriculum. And in a way, it's people basically saying, okay, you've said some things about education. Now's the time for you to show us by putting your money where your mouth is. How are you really going to do this? And I should tell you that what we've undertaken is not just about integrating evidence into the knowledge, but integrating much more broadly than that and much deeper than that. And I want to give you that context before we talk about how we're integrating evidence. So here's what we're going to tackle, is showing an example. I don't think it's the example. It is a worked example from our work in Athens, Georgia. So you have a look at it. And anytime. This is our building. It's a 160-year-old mill building on the river, the Oconee River. This right here is the mill race where the water from the river goes under the building. And it's still there, and on rainy days, the building howls with the noise of that going under, making large groups quite interesting, actually. In any case, a lot of distractions. Athens, a wonderful town, university. I'm told there's a football team there. So we had to get our students' attention, and we were hired pretty much in 2009. And in 1 year, we were to open our doors. So in 2010, we had to have a first-year working curriculum. And we've worked very hard to get this done, and yet it's still a work in progress. We've just finished our second year. And we took some time, because it was 2010, to reflect on the prior 100 years as to what we had learned from medical education. If you were opening a medical school in 1910, you would have had access to Flexner's report and his holding up of Johns Hopkins as the model, in which now has become almost enshrined this whole business of the 2+2 curriculum, 2 years of basic science and 2 years of clinical rotations. Most people think of him as the person who made sure we had research universities associated with medical schools, and that's true. In addition, he was a big proponent of supervised or graded supervision on clinical experiences, that you couldn't just lecture at students then and push them out with a degree. They actually had to learn through doing. And there are other things attributed to him as well. At the time, though, the shape of the medical schools reflected these several beliefs that many people still hold. These are foundational beliefs that have been very tenacious in medical education. And one of them is that foundational subjects can be taught early and only once. Let's take anatomy. We teach anatomy in the first year in many places. Why do we only teach it once? Why is it that we overload our students in the first year before they understand why they need it and never come back after they've gone to the clinical rotations and go, hey, I want to become a chest surgeon. Now I should know a lot more about chest anatomy than I did when I went through anatomy. Why do we teach it only once? That it was good to inculcate general mental faculties, that the study of disciplines was primarily that it would stretch and strengthen your mind. And these were people who made sure we studied Latin and philosophy to stretch and strengthen their mind. And that also, that to use knowledge, students had to master its methods of inquiry. To use a beta blocker, you have to have done studies on beta blocker receptors and ligands. And we've learned that's not exactly so, but anyway, more on that. And that also the notion then was knowledge would change slowly, and that students would be able to integrate this knowledge all on their own. This is akin to thinking that you could go into a donut shop and say, I'd like a chocolate glazed donut. And someone hands you a cup of flour, a teaspoon of baking soda, a tablespoon of cocoa, and a heap of butter, and say, there's your donut. Well, that's what we're doing right now in most medical schools across the country. Is that me somehow that I'm doing? Oh, somebody has their cell phone? Okay. Well, as long as we're not being signaled to evacuate or something. If that's true, you let me know. And one of the biggest problems is this idea that transfer will happen automatically. Now, what do I mean by these last two words? Integration. Most people talk about horizontal versus vertical, but I think of integration as the deliberate putting together of any knowledge, anything that would guide decisions. And that could be horizontal, disciplines that are taught in the same year, or vertical, the clinical and the science. And transfer is this idea of using knowledge acquired from one context to solve different problems in other contexts. And this is what the learning scientists say is the holy grail of education. They want people to learn in one context and apply in another. Most of the learning science studies have shown that we apply best in the context we learn it. So for instance, divers have been checked on things as mundane as spelling words, and they've checked them on land and in sea. And the ones they learn down in the deep, they spell better down in the deep than they do on land. And the reverse, the ones they learn on land, they spell better on land. The knowledge we know in a classroom setting, we don't necessarily know when we're taking care of patients. It doesn't transfer automatically. Again, there's this idea that these things will passively and easily and automatically happen. Whereas the learning scientists for the last 3 decades have taught us that it takes a lot more active transport. And now that we have functional MRI, and now that we have PET scans and other imaging, and better ways of measuring cognitive tasks, they've been able to label the glucose that shows us just exactly how much energy it takes to learn or relearn things. And it's fascinating that if you already have a belief, you use less energy than if something is counter to your belief. And why is that? It has to do with neural commitment. When we lay down a memory trace, we're putting tissue from one cell to the next. Dendrites, molecules, we're committing to certain memory traces. If we then find countervailing arguments that make us change our mind, we have to decommit that and recommit something else. And that literally is a biologic contributor to resistance to change. Not only do we psychologically want to defend the knowledge we spent so much time gaining, but we have to recommit neurons. That's hard for us, all of us, not just doctors. So here's our first year class. They arrived, very bright, very eager. And we said, we want to help you learn by engaging you more in active learning, that there'll be context for the content you do, that we will have you learn in teams, like you'll practice in teams later, that we want you to build coherent explanatory narratives, not just memorize a lot of facts that are unrelated, but build explanatory narratives. Think about this. If you were to walk up to a bunch of kids on the street now and say, who's Professor Snape and what does he teach? Many of them would know. Why? Because they've either seen the movie or they've read the book. And without meaning to learn, just hearing the story, just being engaged by the story of these people they come to care about, they learn a lot of things, like who Professor Snape is and what he teaches. It's actually easier to understand complex phenomenon when you see how all the pieces fit together, you see how it all works, and you can see the pieces and their relationship to others so that you can begin to name them and tell their story. Otherwise, it's a lot of facts to be memorized separately. We wanted to use cognitive scaffolding, more on that if you'd like. Of course, this idea and this idea, the idea that to become expert in anything, the studies that the expertise literature suggests, as you probably know, that it takes over 10 years and 10,000 hours of deliberate practice to get good at something. And we wanted to integrate across many levels. The issue about active versus passive, I'm here at the NIH, I figure you can handle a biologic analogy. It's like cardiac cycle. Diastolic learning is the passive filling learning that many of us experience during undergraduate and preclinical learning situations, whereas systolic is more the active learning. But they do different things. Here you can acquire facts and you can identify what you don't know. Here you use the facts, so you have to organize them to use them. And by applying and transfer, you lay down, you commit new neurons to how we use this knowledge. So instead of being inert in our knowledge cupboards in our brain, we get practice opening those cupboards and pulling it out and using it regularly enough so that now we can transfer more easily, more readily. Yes?
So if students are learning to create this new method, which sounds really good, like you're learning, kind of on the job kind of learning, how do they do with testing? Because in the end, they care about testing.
They do. They do. So the question has to do with how they are doing on the testing. And I want to show our sample week, and I'll get back to your question about how our students learning this way. Oh, yes. Thank you. I should have remembered. We have... Do you want to ask it again?
I'll ask again. I said that I think this is a really good idea. You know, it's on-the-job learning, but I wondered how the students do with testing, because in the end, they care about their scores and placement when they graduate from medical school.
They sure do. Thank you for your question. And what I want to show you is here's our sample week. So in the first year, it looks like this. In the second year, it's very similar, except the small group learning, case-based learning happens in this time block. They start in the first year with small group, and they have then large groups, which you might call lectures. We have histology labs, anatomy labs, community health projects, clinical skills, and so forth. Notice over here it says weekly assessment. And what this represents is a chance for students to check their knowledge before they leave the week. Now it takes the form of 30 multiple choice board-style questions each week. Test-enhanced learning, the learning scientists tell us, means that if you have regular checks of your knowledge alternating with cycles of learning more and relearning, you do better on final exams and tests. So by the end of 2 years, our students have experienced, whether it's weekly assessments or module final exams, over 3,000 NBME-style multiple choice questions that they've practice questions that they got credit for in the form of grades. So there's a certain amount of facility that comes with doing it over and over and learning to apply your knowledge to assessments on a regular basis. People say, are you teaching to the test? No, the primary reason is test-enhanced learning. We're helping them check their knowledge. A side effect of this is that by the time they hit their step 1, they've done a lot of practice of this kind of testing. And yes, they're nervous, like every other medical student all around the country is nervous right about now, because our second years have just finished their second year, and in the next month and a half they have to take step 1. I've yet to meet a class of medical students who's not nervous at this time. Are they any more nervous? I reckon not, as a group. Individuals, sure, because humans vary, but I think they're as well prepared as most groups as well. Let's look at the other stuff. We've got a thing called Essentials of Doctoring, or Essentials of Clinical Medicine, and that's where we do some learning about evidence-based practice, a thing called Community Health, and a thing called Clinical Skills. More on those in a moment. But I want you to show you that it's a composite thing, and each week is organized around a week's theme. So what's an example? Well, 1 week in the fall, they start on Monday morning with a case of a young man, a senior on the football team, who has an injury to his shoulder. And after that injury, feels pain and he can't move his shoulder, can't move his arm. And they realize to solve this problem, they have to learn about the anatomy of the shoulder and the anatomy of a thing called the brachial plexus, which is a complicated structure. So that's 8 to 10. Their very first large group is an anatomy presentation about this complicated structure of the brachial plexus. The next one is a histology presentation about the histology of nerves. The next day they learn about action potentials and the physiology of nerves. And their anatomy lab is the anatomy of the shoulder and the brachial plexus. And clinical skills is the examination of the shoulder. So that what we're trying to do is integrate not just by adjacency, where these things are adjacent, but that the weekly learning objectives and all these things are different parts of the elephant. So they see all these pieces next to each other and they inform each other. And because we're talking about various clinical decisions, it allows us in this sort of session to deal with the evidence about that kind of decision. While we're at it, the cases are fairly broad. We've decided it's not just the standard thing. We're going to include from genes to society, all the determinants of health we can throw in there. They're authentic clinical predicaments, and they unfold over 3 days. So in some schools, problem-based learning is one case, you get everything on the first day, and then you have to do follow-up. In our situation, they get a part of it, they discuss it, they get another part, discuss it, and so forth. Then more parts here and more parts there. So there's a sustained mystery until Friday. And that gives us a chance to learn between Monday and Wednesday and between Wednesday and Friday new stuff that relates to the decisions that are being made. And we coach them on how to find knowledge. So we have a librarian who's on our faculty, and she teaches searching, and she teaches asking questions. She helps us teach appraisal. And we have sessions on the determinants of health, fully biologic, psychologic, and sociologic. We think for all these educational notions on the side, this was from a presentation I gave recently to the College of Ed. There's a bunch of reasons here, educational science-wise, but these are boiled down to the intermediate step or surrogate marker of improving integration on the way to the longer-term outcome of improving transfer. So that's how and why we teach science in the cases, and that provides then some of the context. And we've organized around lots of doctoring tasks, decisions, problem-solving, conversations either. You know, a lot of times we say, oh, my doctor doesn't know how to talk to me, and I wonder, did they ever learn? Okay, so we have sessions on not only the easy ones, the familiar ones, how to break the bad news, but even talking about an undiagnosis, talking about the adverse effects of treatment, very specific. And so then again, you say, well, wow, we've just told them here's an adverse effects of treatment. Why not have the evidence about the frequency of how often that adverse effects appear right then, so that when they need to use it is the time we bring the knowledge. So that's what we mean by integration, that it's knowledge in time for their learning. And it comes from any discipline. We've decided not to spend so much time thinking about the root discipline, that this comes from anatomy. Because we don't do this in language, right? You aren't told that in order to use the word quiz, you have to learn its etymology. You are simply allowed to use the word and employ it. The word pattern, does it really matter whether it was Latin or Greek that it came from, and its history over time? We spend a lot of time in medical education declaiming the origin of knowledge rather than emphasize how that knowledge gets used in everyday practice. A tradition we should probably give up, because our students recognize it primarily as an elaborate 2-year-long hazing ritual that they then practice a kind of intellectual bulimia. On step 1, they disgorge, and they don't absorb, and they move on to the clinical years. So then, if you're thinking this way, you could organize yourself around these types of decisions and the types of evidence you need. If you're going to talk about risk or harm, talk about prognosis, talk about treatment or diagnosis, and each of these have subgroups, okay, subtypes and subcategorizations. But if there are 4 main areas, we've recognized that those appear in a lot of our cases, and that if we think about those skills we talked about, asking, acquiring, appraising, applying, and then acting and assessing, and then we add the third dimension of the context, either single patient, groups of patients, whole populations, or what I think of as future patients, the skills for lifelong learning. If you map out that 3-dimensional grid, then you can begin to say, well, actually, there's lots of opportunity as long as we do this slicing. Rather than trying to teach the whole thing, we can reinforce in the cases in the science module the risk from something. So our very first week, our very first case, I hope that rising first years aren't listening, is a patient with sickle disease. They don't know that. They just see a young child with pain. And we learn about the gene associated, and we learn about the risk of transmission and so forth. And so early on, there are quantitative notions from genetics that are coming in. And so we begin understanding risk, the quantitative expression of risk, and how to talk about it with our patients in the first week, as they're learning the science of gene product and red cell makeup and so forth, and even hemoglobin cooperativity, or whatever it is that gives us that gorgeous S-shaped curve. Is it cooperativity? I may have lost track of that bit of biochemistry. In any case, we try to weave it all together. Now, for the stuff that needs explicit teaching, we've done some work in community health, in the essentials of clinical medicine, and in the clinical skills part, and I want to turn to those. In the first 2 years, we talk about these skills with these headings in those areas, and they learn to appraise evidence in these types so that they can find it and use it and make sense of it. In addition, in the community health projects, we've taken this idea of learning through doing. Instead of just a few lectures on community health, in the first semester, they work with one of our partners in the community, and they do a needs assessment. And in the second semester, they do a brief intervention targeted at those needs. First-year medical students, working with the university health, that first year was on sleep deprivation, polypharmacy in the aging, depression care. This, you may know that Athens is home to a large creative community, many of them musicians, but other types, and a lot of them what's the polite term, under or uninsured, and so they are provided care there. There's also asthma at Head Start, and this I think was geriatrics something. I can't quite remember what that is now that I see it. The idea being that yes, they have some introductory ideas, but then they also learn through doing. And not least in clinical skills, we have them, as I mentioned, learn the examination, how to do it, but also learn stuff about how accurate it is. Okay? And it includes things like the delivering the messages we were talking about. Are you familiar with this Rational Clinical Exam series in the Journal of American Medical Association? David Seimel, David Sackett, and Drummond Rennie are among my many heroes, and here's why. They've stuck with, since 1992, the deliberate collection and updating of what is known about the accuracy of bits and pieces of the clinical exam, so history or physical, for the diagnosis of certain conditions. It turns out, for instance, that there are 43 different maneuvers for the diagnosis of chronic obstructive pulmonary disease that have been described over the years. 3 of them have sufficient accuracy and reproducibility that we now teach our students those 3, because the others, in even experienced hands, aren't reproducible enough or accurate enough to be worth their time learning. Now, when we were talking earlier about speed, here's an example. Why do we teach eponymous bits and pieces of the physical exam that have likelihood ratios of 1? Make no distinction between those with and without disease. Why do we make our students learn them? Why do we insist on testing them in clinical skills, the OSCEs? And why do we insist on demonstrating them at the bedside? Is it because we're teachers of history? Is it because we're related to those people whose names are on there? I would like to know why. I want to know why we can't concentrate our learners' attention on the few findings that matter and really help us not only know how to gather them, but how to interpret them and how to use them in clinical medicine in a way that speeds them up as well as makes them more accurate at diagnosis. And so forth. The bits of the history of physical, there are also other tests in that series. So that's how we put all those pieces together into our curriculum. And one of the things that, yes?
This makes a lot of sense. I'm just...
Oh, it may not be on. Speak into my microphone.
Now this makes a lot of sense. I've always wondered, though, in a curriculum like this, how do you teach something that may not be amenable to intermittent 2 or 3 hour sessions like immunology or genetics, where there's a large amount of information and sort of that it needs to be taught sort of over a relatively short period of time, because a lot of it may be new. And it may not work to teach 2 hours of immunology now and then 2 hours of immunology in 2 months from now.
Thank you for your question. I think it has several parts. So how do we deal with the large groups? So do we have large groups? And we clearly do. And how do we teach new knowledge along with old knowledge, if you will? And, if you take the idea that we should be teaching our best knowledge, whether it's new or old, our most reliable, most understood, we try to have that selection go in there. And then the issue about pacing is interesting. I've found over the 2 years that at first many of our scientists held the view that you appear to hold, that you have to teach all these things together. And I think now some of them are starting to change that view, that if they experience a case in which that knowledge is directly relevant, and then they hear that knowledge in the large group, and they see that case use that knowledge and so forth, and they're tested on it, then they can build that knowledge more longitudinally. Now, I don't mean once now and then once a year from now. We try to get some sequentialness out of it. But it isn't necessarily so that the only way to learn the next hour of genetics is immediately following the first hour. In fact, many of our scientists are coming to understand that if they go away and really learn those things we just asked them in the first hour, that a few days later or the next week, they can pick up the thread and move forward, particularly if there's a case that makes that come alive. So I take your point, yet what I see in our scientists is they're seeing, oh, we should teach at the pace of their understanding of my material, which isn't necessarily the speed of our speech or the speed of our mouse clicks or how fast the slides can go by. I recently attended a lecture where in a half hour someone had 96 slides. Now, to my way of thinking, that's really not about learning. That's a kind of shock and awe campaign. Yes? Speak loudly, we will hear you. Oh yeah, okay, we'll use the microphone. Oh, that's right, for the webcast.
Well, I guess following on this gentleman's question, I really, I might want to hear the evidence that that is the case. I'm thinking about, I recently taught EKGs to first-year students and then in this module-based second-year students, and most of the time was spent reminding people what they had previously learned. So, you know, I mean, there must be a reason why in college we take a semester of chemistry and not an occasional lecture in chemistry. I have to admit that I'm skeptical that someone could take a large body of scientific knowledge and learn that as effectively episodically as they would without the constant reinforcement of reminding what we were talking about yesterday.
Well, thank you for your comment. And I actually, I suppose I did not bring the slide that shows you exactly how coalesced these really are. For instance, when we're in musculoskeletal module, it's 7 or 8 weeks of learning a whole lot about muscular anatomy and bone anatomy, and those pieces come fairly fast and furiously. At the same time, they're also learning about bone physiology and muscle physiology and bone and muscle energetics and metabolism. Do you see what I mean? So it's not as separate as I must have somehow communicated to you. It's not by weeks or years. It's really more that it's not necessarily all the same week, because the pieces that go together for those topics go together, but the next week we pick up with quite a bit more anatomy and genetics and so forth. So there is a regionalization without necessarily a total fragmentation, if that helps you. Yes, ma'am?
But is there any acquisition of an evidence base to suggest that one way of teaching these subjects is superior to the other?
And I would be delighted to stand here one day and tell you we have that evidence. I think what we have is in medical education a number of studies about problem-based learning that either show no difference in their knowledge or some modest improvement in their knowledge for regular forms of problem-based learning. This is quite a bit different from regular problem-based learning, as I hope you see. It's quite a bit modified. And we've done what I think of as imported a lot of ideas from general learning science about how to get this done. From the general learning science, pieces of this have been tested and shown that they lead to better knowledge. But I don't know that we've done this experiment where all these pieces put together have been demonstrated to do better. I had hoped to randomize students to one campus or another, but that got roundly rejected, I'll say. Had we been able to randomize, we might have been able to control for all those wonderful things we call confounding variables, which means that their likelihood of success in the traditional curriculum, a more traditional, I'll say, curriculum in Augusta versus our curriculum. But nonetheless, the measures of our curriculum or of our students say they had the same entering MCAT scores, the same entering GPAs, a similar distribution of backgrounds as those in Augusta, and so there may be some comparability. And I reckon we'll end up demonstrating that the knowledge measures are similar. But I think you'll see that perhaps the skill measures will be different. Their ability to use evidence in their everyday decision making may be different. But even passing the boards at a similar rate will be still an achievement of this. It shows that it can work this way. I have lots of people who are sure that it can't work this way, primarily for the reason that it's not the way they learned. And that's the kind of creationist view of education, that we should do it the way they did it. You had a question.
Yeah, Professor, I studied at University of Missouri, and
Yes.
They use a problem-based learning structure that's, I think, very similar to yours, where it's each week is based on a theme, and there was some evidence collected. There was a big bump in the Step 1 scores in the years following the adoption of that curriculum. I think there is some evidence
Right.
that shows that this works. I'd also like to mention that this, at Missouri, this curriculum was created not by MDs, but by EdDs and PhDs in education who came in with different biases, hadn't had a medical education, and so were free of the biases that you have somehow fortuitously escaped, that everything has to be taught the way it was in the 20th century.
Well, I appreciate you bringing that up. I hope everyone heard two points in response, and I think it connects. There are other stories, right? So we have one of our people that teaches with us came from UTMB in Galveston, and they had a similar experience when they went from the traditional didactic to the problem-oriented and problem-based approach with small group with cases. If you accept before-after study evidence as useful, they had for the several years before X, and they had for the several years after almost 1.3x in terms of their board score. So quite a big jump, and it was sustained. It may interest you that I used some of these same ideas in my prior location when I overhauled the medicine clerkship, the internal medicine clerkship. As a clerkship director at one point, and we went from 4 hours in a row of subspecialty lectures, can you imagine, by the same person in the afternoon. And did I leave out that you had to go whether you'd been on call the night before? Okay, you can imagine how lethal that was. And our students scored at that institution as they entered medical school at the 50th percentile, and on step 1 at the 50th percentile, and no surprise on this shelf exam for the clerkship at the 50th percentile. But using many of these notions, we overhauled the clerkship, used more active forms of learning, did some of the same ideas, and for the next 2 years, their shelf exam scores went to the 77th percentile. I was checking the shelf exam scores primarily because I was worried that it might go down. Okay? I didn't really expect it to go up, but it did go up. And those data are probably not going to be published for the following reason. One of the coolest things was we had no failures in that clerkship for academic reasons. Whereas in prior years, there had been several per year that couldn't pass the shelf exam. Nobody flunked for academic reasons. And it transferred. Their step 2 scores were higher than that school had seen, including one student who scored 2 points shy of the highest possible score. Not happened before at their school. And again, no failures among first-time takers. Nobody really wants to own up to that. My view of this is that the evidence out there shows, while incomplete and not necessarily randomized evidence, shows the same or better outcomes in terms of standardized test measurements of knowledge. But it is incomplete, and I do look forward to better, more elaborate studies that control for more confounding. In the meantime, if you knew something that would help even the weakest people in the class succeed where they hadn't succeeded before, why wouldn't we do it? Particularly when you're starting from scratch and you're given the opportunity, the tabula rasa, that may not be pronounced properly. Anyway, that white tablet to try and start from scratch and not have to reinvent it. You have a question, sir?
I do. I'm a dentist as a profession.
Yes?
And I wanted to ask about whether they have successfully applied this model to other types of medical education, such as dentistry, PT, nursing, etc.
So I'm aware of several, though not in dentistry. By the way, I should say there is a center for evidence-based dentistry in the United Kingdom, and there is a movement worldwide for evidence-based dentistry. I'm not sure about dental school education doing this, the whole piece that we have here, but I think there probably are. I did some years back, this is going to be about 4 or 5 years ago now, when I was at Oxford at the EBM course there, meet some people from one of the schools in the Netherlands in dentistry, and they were talking about how they had overhauled their curriculum, but I do not have enough details to be able to answer your question fully.
The problem I was going to suggest is some of the schools in the United States do incorporate with the medical school to teach you basic sciences, but unlike us, the medical school doesn't, you have to learn some technical skills and examination and whatnot, but then for us we have dental anatomy lab where you have to wax teeth and you have to learn how to do operative dentistry procedures. So it seems like there would be a very difficult approach to incorporating that with the basic sciences just due to how the curriculum overlap.
Well, people have asked me how I've succeeded in the things that I've done, and usually my answer is something like the combination of good luck, opportunism, and sufficient naivete to believe that it might still be possible despite all the wiser people who tell me it is not possible. I can't help but wonder. I wonder who's tried it, and I wonder how it succeeded. I suspect there are schools out there trying some of these ideas. I do think it's true that each profession is likely to have different shapes of these ideas. It's perhaps the difference between a method and a personal style. You might have the same method, but with different shapes to fit the profession. But I wonder how many of these ideas, there have to be, why learn about the anatomy of tooth enamel? Is it because it's there, or is it because you're going to have to make decisions diagnostically and therapeutically about it? And to the extent that the decisions can help us organize what people learn so that that the knowledge is guiding that decision is brought to bear, then I think there's a good chance it could affect. But I just don't know enough about dentistry to answer you. You have a question, or you're?
I do.
Okay. Yes.
So I think one of the areas where the traditional curriculum really fails is teaching kidney disease and renal physiology. And
yes.
Part of my job at directing a kidney disease program is to try to improve outcomes in kidney disease in the primary care setting. And whenever I talk to physicians, I sort of say, well, one of the biggest obstacles is most physicians spend their entire careers in recovery from the second-year renal block, and that always gets a knowing laugh. And I'm curious if you have any anecdotal experience or more than that to comment on how this curriculum works better in kidney disease almost as a litmus test.
Well, thank you for your question. I'm not sure we have enough outcome data to tell you about how well it works better or does it work better. I can tell you that we've taken the
Anything would work better.
Right. Well, see, I feel the same way often about statistics and epidemiology. Like, people hate it before I get to them. Why? But yeah, so why do they hate the kidney? But the thing is, a lot of people don't understand the enormous functional beauty of, like, the proximal tubule cells. They're amazing cells. They do these amazing things, and they're complicated. But they're very function-oriented, right? So there's a form kind of function beauty. But it's not always portrayed that way, is it now? And I would say that the experience of many students is that renal physiology, cardiovascular physiology, and pulmonary physiology are some of our most difficult areas of physiology, and the corresponding areas of pathophysiology and pathology are also quite difficult. But we've done it. It remains to be seen how well we've done. I was actually asked to give a non-nephrologist, a kind of non-expert view of managing patients with chronic kidney disease, what I think every doctor needs to know. Let me go back to my experience as a clerkship director. One of the big challenges I faced at that time was overload, curricular overload, because I had these specialists saying that they needed to know everything in kidney about, say, mesangial-proliferative and membranoproliferative and so forth, and my third-year students couldn't sort acute kidney injury from chronic kidney disease. And I was faced with the problem that they were trying to teach the entire discipline of internal medicine and nephrology in that 1 4-hour session. It's my only chance, they would say, and I've got to get it in there. Well, that's not really going to happen now, is it? You can't get it all in there. I don't know what all is, but after the first hour of 4 hours, they have shut you down, if not sooner. So, as a consequence, by trying to teach everything, as far as I could tell, they learned close to nothing. So I thought, what if we built the other way? Compared to learning nothing, what if they learned one thing, and then a second thing, and so forth? So after hours of negotiation, I finally pointed out, look, for every 100 students at that medical school who came, 10 to 15 were headed into careers in internal medicine. Let me say that another way. 85 to 90 were not. We needed to orient our clerkship to teach not internal medicine for internists, but what every doctor needed to know about internal medicine, even if you were a surgeon or a pediatrician. And if we did that, it wasn't that hard, wasn't that long. Eventually they said, yeah, you know, you're right. Acute kidney injury, that's pretty important. Chronic kidney disease, that's also important. Maybe 1 or 2 other things. And we focused it. And again, the shelf scores went up. I was worried they might go down because we were teaching fewer facts. But although the number of facts floating in the air were fewer, they were a lot more coherent. And I actually think that instead of the standard 5% or less retention and transfer that most people get out of most lectures, most of the learning sciences tell us that the retention and transfer from active learning is more in the neighborhood of 25 to 50%. Now, it's still not 100. I can't tell you how many people I've heard that say that. But which are you putting your nickel on? Particularly if it helps the people at the bottom of the class. The people at the top, they can learn anything. You could put them down in the center of armed conflict in Kosovo or something, and they're still learning. They're like, whoa, I didn't know any of this. Would you look at this? But they're going to be okay. What I'm much more interested in is the whole range of our learners, making sure it's possible for all of them. And when we did that in nephrology in internal medicine, the scores went up on those quizzes just as well. Same thing here. Our students have learned renal physiology and pathophysiology partly because this approach, but now if you look at the overview, in many schools, in the first year you have learning, mostly lectures, about normal human structure and function. And then in the second year, learning about human disease. And then in the third year, you get to clinical sciences. And what we've tried to introduce through the case-based learning and our approach is that in both years, they're learning pathophysiology. In both years. But in this year, they're learning the normal by comparing and contrasting it with the abnormal. In the week, they're learning cardiac output. They have a patient with heart failure, but it's not primarily to learn the disease that causes the heart failure, primarily to learn the syndrome. And they learn in the first year what the renin, angiotensin, aldosterone system normally does by comparing and contrasting it, the normal to an abnormal. And why, when a patient with heart failure lies down at night, do their lungs fill with fluid and they have trouble breathing? Why doesn't that happen to everyone in this room? How do we stay out of heart failure? Is the kind of, and what is the normal? But again, by comparing and contrasting it with the abnormal. In the second year, we remind them of the pathophysiology and then focus on the diseases that cause it, and thus theme and variation. So in the first year, the heart failure patient has a problem with muscle pumping. In the second year, we introduce valvular disease with the pressure or volume loads that cause it and so forth, so we connect them. Interstitial lung diseases, we just recently did this. Okay, there's almost Avogadro's number of possible interstitial lung disease, and they can't just do it by memory alone. But we had a week that was organized around it. 10 or 11 pathophysiologic categories with exemplars in each category. And we then said, and the crucial thing is the exposure. So by organizing and connecting through the coherent narrative pathophysiology, which includes, again, from genes to society. So in effect, they spend 2 years studying pathophysiology, connecting across all these sciences. And why not include when you say, okay, well, you know that heart failure is associated with excess activation of renin-angiotensin. When we talk about its treatment, this is where they work. They interfere with this activation or something like that. And then it's not too hard to say, well, how well do those treatments work? See how those pieces do fit together. Remains to be seen, though. I suspect, like many things, it'll be either roughly the same or better. But I share your pain about nephrology. I'm not a nephrologist, but because I'm a general internist who's unafraid to teach, I'm the cleanup teacher. So I ended up teaching a fair amount of the kidney pathophysiology. I'm sure there were other questions and then I ignored them, so I apologize. Yes, ma'am.
I just wanted to know, are you doing anything to kind of extend this model to the pre-med curriculum? Because, I've heard you use the word pacing, and as a pre-med dropout, I ended up going the PhD route. I felt that psychology classes were very much this way. It was applied. I understood, in my psychology classes, why I had to memorize, the regions of the brain. It made sense to me. But I really floundered in the classes, that were kind of in the old model. And, medicine lost me, to the psychology side. And I wonder if I would have succeeded had this model kind of gone down to when I was 18 years old.
Well, I'm sorry that medicine lost you. But perhaps psychology has the better for it, or whatever your field now is. Let me say that I think the tectonic plates are moving in that direction, even if I don't do it, but I'm trying to play a role in my local situation. First, the tectonic plates. Have you heard already about developmental, the Boyer, the Dreyfus and Dreyfus model, developmental model of competence? Has people already talked you through that? Well, I'll tell you what. 2-minute sidebar on that. The idea is that professionals don't come out of the can fully formed, right? You aren't born an excellent teacher or an excellent doctor or an excellent scientist. You have to grow to be that way. And that growth is not necessarily predetermined simply by going to school. That growth has to do with the development of particular competencies. And if you take a developmental stance, i.e., you start somewhere, novice, you become expert, what are the milestones that you can begin to recognize as they move towards competence? And what are the experiences in coaching and feedback that you have to get to reach that stage? And if you take that general idea, that is what a lot of people mean. The plus side of that is what people have called competency-based education. Now, this has been known for a while. This is not necessarily a new idea. In fact, the ACGME, the crediting body that accredits graduate education, some years back insisted that residencies, and you may have to live with some of this in your work, residencies adopt a core competency model for assessment of readiness to be certified. And they identified 6 core competencies. Let's see if I can do it. Medical knowledge, sure, that sounds right. Patient care, sure, we're for that. Communication and interpersonal skills, okay, yeah, that's good. Professionalism, we're all for that. Then 2 that are a little less clear, practice-based learning and improvement, and systems-based practice. But then when you look under the hood, practice-based learning and improvement has a lot to do with what you and I might call evidence-based practice. And systems-based practice has a lot to do with working deliberately, effectively with teams to provide health care. And if you start looking at the Canadian system, they have a different set of competencies, but in the last decade or two now, at the graduate level, they have moved in the direction of competency-based education. Well, as you can imagine, the magnetic force, gravitational force field of residency got the attention of a lot of medical schools. And surprise, surprise, a lot of medical schools are now going in the direction of competency-based education. And it may not surprise you that they're roughly the same 6. A year or two back, the Howard Hughes Medical Institute and one other group, AAMC perhaps, put together a study of, is there such a thing as competency-based education for undergraduates? And they've released a report. There are 2 parts of it. One is the science preparation, and another is the humanistic that has just recently been published. And those are the tectonic forces that will eventually get done what you're talking about. What we're doing on a local level is, as we're doing this in a competency-based education way, we're also talking with the people right across the street in the College of Ed and down the road in the Biomedical Health Sciences Institute to see if they'd like to align their education in a way that prepares UGA's graduating seniors for success in our model. I think they're waiting to see if our model succeeds. But assuming it does, along the lines of what we were talking about before, assuming it does, then I think they might be willing to have a go at it, because they were quite interested. Now remember, this is threatening to a lot of traditional departments, because I'm in a department of biochemistry or of physiology or anatomy, cell biology. Wait a minute. You're going to have a course and it's not going to be called biochemistry or cell biology or anatomy? And I'm have to teach this, but I won't get credit? So we have to find ways to administratively solve the barriers to interdisciplinary education. But that sounds plausible. That sounds like we might be able to get it done, but they won't give it up for nothing. I think what they need to give it up for is more integrated undergraduate pre-med preparation. But there's a lot of persuasion left ahead. Hard bargaining, I'm told, is the way they say it here in Washington. When they talk about all these international peace collaborations and so forth, hard bargaining lies ahead. What other questions do you have?
Thank you.
Yes.
My question's a mirror of the last question.
Yes.
How can we apply these principles to continuing medical education?
Thank you for asking. Let's not forget this line back here. Most of what is done in the name of continuing education, as you know, is a repeat of preclinical medical education, hour after hour of lecture. The randomized trials show that there's no change in clinicians' knowledge or their decision-making on the basis of a standardized lecture. In fact, it's a very creationist view of medical learning, that you learn anatomy once, you learn something once, and then after that you don't have to learn anything new, you don't have to unlearn. The studies that have shown effective things have showed that there are people that have figured out ways to help people unlearn some old ideas and learn new ideas through more active learning, whether it's workshops, a thing called academic detailing. So instead of someone selling you a drug product, someone comes out and sells you a new idea by showing you how it makes you a better, faster doctor. Or other mechanisms to engage people in skill building. There are methods of effective CME. In fact, there's a movement among CME now called evidence-based continuing education, i.e., let's use studies of effectiveness of these methods to guide our efforts. So there's another movement underway of people trying to inform processes of continuing education. What lags behind? State approval, the certification. There's a lot of administrative processes that regulate CME that aren't yet there. We have another huge barrier in that one of the major forms of financial support for continuing education is industry. And I'm not here to start a ruckus, but there's lots of problems with that support, and one of the challenges is who's going to pay for continuing education, okay? And if you go back to that water analogy, if you say that we all pay if we don't have current best knowledge, if we go and it's 30-year-old water filled with goo, and we use that for our living and eating, we get sick. Same thing if our knowledge is not current best knowledge. We all in some way pay for it. Eventually, it kind of comes down to how are we going to share the expense of continuing professional development for knowledge workers in healthcare? I don't know that we have that sorted out. But meanwhile, we're trying to help our students build the skills, because one of the essential skills is being able to recognize when you don't know something, turn that hole in your head instead of hiding it. You know, we all hide. We're schooled to hide when we don't know something, right? You're not sure this is true. I can tell by the look on your face. It's all right. Ask yourself, when a teacher asks you a question, what did you do if you don't know the answer? You raise your hand. You raise your hand and you say, I don't know. Well, bless you. But most people do not do that. Most people look down or they look away, try to become invisible. Very few people go, oh, call on me. I don't know this, but boy, am I ready to learn today. It's laughable because we learn from as far down as kindergarten to hide when we don't know. And this is adaptive in situations where knowing already is what's valued and not knowing already is taken as a sign of weakness. But it's maladaptive in healthcare work. Because if you don't know and you hide that you don't know, who pays that price? Your patients or your population. We cannot afford that. So what I want to know is, what are we going to do? I think we're going to maybe make evidence-based practice possible. Oh yeah, there's some people working on that. Because when I started, people would laugh at me like I thought we should look up stuff to know what to do for our patients. And we're going to try and get it into the curricula of medical schools. Oh yeah, there are people working on that. We're going to spread it to any field who wants to. Yeah, there are people working on that. We're going to overcome the barriers to it. Yeah, there are people working on that. But each in our own way, you could take up this idea of, if we're going to make well-informed decisions about whatever my work is, and we're going to teach our younglings to make well-informed decisions after you're gone, how's that going to happen? Each of us could make it happen in our own environment. But it does take, I think, a fair amount of willingness, as Garrison Keillor says, to stand up and say what needs to be said, even if you're shy. Yes, ma'am.
So do you think, what role do you think electronic health records plays into this, or does it?
She's going to have you repeat the question.
What role does electronic health records play into your curriculum?
Into our curriculum?
Or in general?
Into the future? Okay. I look forward to the future day when it helps us. Right now, if you're in a clinical environment, in most situations, in most electronic health records, if you want to look up something, you have to sign out of that record because of all the HIPAA and the patient confidentiality requirements that you can't actually have it open while you have other things open. And you have to go somewhere else or use some other device to get knowledge. This seems to me fixable. Now, I'm not the programmer that's going to make this happen. I don't program at all. But someone should be able to figure out how to have knowledge resources woven right into the patient care flow resources so that when you need help working up someone with hemoptysis, or when you want to choose to use a resource about the adverse effects of a medicine, you don't have to leave what you're doing and go somewhere else. And again, that water analogy, right now when you want to go get information, it's the equivalent of you've got to stop what you're doing and go down over here to the riverbank and take your bucket and then go boil it yourself to get rid of the impurities. And add the iodine and then wait a few days and then you have knowledge that's free of bias. Why isn't it like the tap? Why don't the electronic health records find a way to get knowledge resources in focused amounts at just the right level that represent current best knowledge? And not just the guidelines that they want you to follow, but current best knowledge that allows you to individualize care and personalize it. We don't have that yet, but it's going to happen. Somebody needs to figure this out. There was another hand up, but I've moved around so I've lost track of where it was. Okay. Well, I'll tell you what. Let's skip ahead to the end. Here's them imitating me. I take it as a compliment. They did this to entertain themselves, but it also entertains me. I've already asked you for questions. This is another shot of our building. I want to thank you.
I'm just going to close this out. Dr. Richardson, you did exactly what we wanted you to do. I think to a person, we enjoyed the presentation, and there's a good chance that we'll remember some of what you've said. I want to thank all of you for participating. NIAAA and NCI's Division of Cancer Prevention worked with the Office of Disease Prevention to sponsor this activity. We'll look forward to seeing you again.